Good evening, one and all. At the outset, I would like to thank Kumaravil sir and Team Receptor for this kind invite to be in Madurai. I think I'm coming to Madurai after nearly 30 years. I last came in when I was studying in 4th standard, I would say. And thanks again, and thanks to chairpersons for the kind words of introduction. So my topic is osteoporosis, a neglected problem. So it's a vast topic, so I'm just trying to touch up all the areas. I will not be going into detail into all the aspects due to a short of time. And this is the agenda. And yes, just a prototype patient in the clinic, 60-year-old, no significant past illness, postmenopausal since 2005. She had a Colles fracture in 2016, and again backache and followed by detent compression fracture. She was evaluated for malignancies and hyperpara, which came out to be negative. You can see the calcium, phosphorus, PTH values, and vitamin D was definitely on the insufficient side. And the DEXA, or the bone mineral density scan, showing that the T-score in the lumbar spine is minus 4.5. So definitely that is low. So we'll go into the definition. So osteoporosis is a progressive systemic skeletal disease and low bone mass and microarchitectural deterioration of bone tissue. So that is very important. Not only the bone mass, the microarchitecture can also be get deteriorated, and that results in the bone fragility and susceptibility to fractures. Epidemiology, you can see 1 in 3 women more than 50 and 1 in men more than 50 can develop osteoporosis, so that is definitely high. And the lifetime risk of dying from hip fracture is as same as that from the breast cancer. So you can see how deep the problem is and how we are neglecting it. And osteoporotic fractures in men are more common than myocardial infarction and even prostate cancer. So that itself is again another eye-opening fact, I would say. Etiology, yes, the primary osteoporosis due to the age and the sex hormone deficiency, part of aging, and the secondary osteoporosis. And you can see secondary, there are many causes. You can see the endocrine or the metabolic causes, acromegaly, diabetes itself, growth hormone deficiency, hypercortisolism, Cushing syndrome, hyperpara, hyperthyroidism, hypogonadism, hypophosphatemia, porphyrias, and all the other causes like the nutritional drugs you can see, especially steroid-induced osteoporosis is quite common. And the other metabolic disorders and the AIDS or the retroviral infections and all these things are the causes for secondary causes for the osteoporosis. Pathophysiology, yes, Dr. Muthukumaran sir had just briefed upon the structure of the bone. I'm not going to detail of that. There are the osteocytes and the osteoblasts and the osteoclasts. These are the 3 main cells in the bone. And the main hormones that act on the bone, the sex steroids, PTH, and the vitamin D. And there is bone formation and bone resorption. Continuously this is happening in our system. And when there is an imbalance, especially after the menopause, the estrogen deficiency resulting in the reduced bone formation and increased bone resorption, it results in what is called as osteoporosis. And in men also, due to the aging-related testosterone deficiency, that can also result in the increased bone resorption. So you can see in postmenopausal women, bone resorption is increased by 90% and bone formation is increased only by 45%. That mismatch results in what we see as osteoporosis. And estrogen and osteoporosis, I'm not going to the detail. Yes, as you can see from the diagram, there is it can help in the bone formation and it reduces the bone resorption. When there is deficiency, the bone formation is reduced and the bone resorption is increased. Screening and diagnosis, baseline lab test, yes, creatinine is very essential to rule out CKD, calcium, phosphorus, alkaline phosphatase, and the PTH or the IPTH, intact PTH, 25-hydroxy vitamin D, and in necessary cases, 24-hour urine calcium, phosphorus, and even the other blood tests to rule out the secondary causes, especially even the TTG, if you are suspecting a celiac disease and all, it will be helpful to rule out secondary cause for osteoporosis. And the gold standard for diagnosing osteoporosis is BMD measurement, that is a bone mineral density measurement with the DEXA, DXA scan, and the dual energy X-ray absorptiometry device. And the T-scores are the ones that are used to interpret the BMD and to correlate the result with the fracture risk. This is WHO and the other ISCD criteria. Normal bone density is T-score -1 or above. Low bone mass or osteopenia when the T-score is between -1 and -2.5. And osteoporosis means minus 2.5 or below. It is osteoporosis. So what is T-score? Comparing an elderly person's bone density with that of a young healthy woman. So that is a T-score. Z-score is comparing with the age referenced matched population. So that is, usually we use the T-score to assess the bone risk for fracture. The T-score is usually taken, the cutoff is minus 2.5 below in the, like the lumbar spine, femoral neck, or even the distal 1/3 of radius. The low trauma spine or hip fracture also, we can see the postmenopausal women are at risk. Osteopenia or low bone mass, minus 1 to minus 2.5, with a fragility fracture at any of the sites is also an indication for looking into the bone mass. Low bone mass or osteopenia and high fracs, I will be coming into the fracs, that a fracture risk assessment score based on the country specific threshold will also be helpful in diagnosis of the osteoporosis. Why it is minus 2.5? That is also a question. So in adult women, the cutoff value of 2.5 standard deviation below the average of the healthy adult range is appropriate to satisfy most of the criteria, particularly for the hip fracture. That is why it is taken, because the risk increases when it comes down below the 2.5 standard deviation. This cutoff identifies approximately 30% of postmenopausal women as having osteoporosis using the measurements made at the usual site. And this is approximately equal to the lifetime risk for the fracture at this site. So that is where the cutoff of minus 2.5 is taken, and it is from the, again, the 1994 study which was published, and that still holds good. And the measurements can be done, yes, the central DEXA is the main device that we usually, the gold standard device. There are other measurements like the peripheral DEXA, the quantitative ultrasound, even the QCT, which will help in assessing the volumetric BMD is also. But the usual central DEXA assesses mainly the aerial BMD. That's why it's given in centimeter square, gram per centimeter square. The DEXA machines are Hologic, Lunar Prodigy, and the Norlens. In India, mostly the Hologic or Lunar Prodigy from GE are available for measurement. This is a device for the Lunar Prodigy, and both Hologic and also the Lunar Prodigy are quite good only. And this is how we position the patient while measuring the bone mineral density. And indication for BMD testing, all women above 65 years of age can definitely undergo BMD testing. All postmenopausal women with a history of fracture without major trauma, with osteopenia, identified radiographically, and starting or taking long-term glucocorticoid therapy for more than 3 months, they also can undergo a BMD measurement. So we should not never diagnose just based on X-ray alone. Diagnosing as osteoporosis is not correct. So that's why BMD measurement is also required. And peri or postmenopausal women with all these features like low body weight, with a BMI less than 20, long-term steroid therapy, family osteoporosis fracture, early menopause, even smokers or alcohol consumption. In this present day arena, we know that women smokers and women alcohol takers are definitely on the higher side. So again, this qualifies for it. And errors can happen due to the positioning. So the technician should be properly trained for that. Artifacts with foreign bodies like them, if there is any implant or artifacts can happen. And those who are on calcium tablet, that's the one, another one that commonly we give is a calcium tablet. It's better to stop the calcium tablet at least 24 hours before the measuring the bone mineral density. So this is how it will be represented, the images, and you can see it is given in the, will give the T-score and also the BMD, you can say gram per meter square. So that's why the aerial BMD, it is volumetric, it will be meter cube or centimeter cube. Then other one is a trabecular bone score. It analyzes the texture of the lumbar spine DEXA image to estimate the trabecular microarchitecture, because just BMD alone microarchitecture will not be able to assess. So that is why TBS is another method that can help, but it will help. It will assess only the lumbar spine microarchitecture, because you can take it like the BMD means it shows the quantity of the bone, and the TBS will help in assessing how strong the bone is. And it reflects features like the trabecular number, connectivity, and even the microporosity. And TBS, you can say more than 1.3, it is normal, good microarchitecture. 1.23 to 1.3 is partially degraded. And if it is below 1.23, it is definitely highly degraded, or the risk for fracture is also on the higher side with the TBS less than 1.23. And limitation, it is only validated for lumbar spine DEXA images. So you need a special software only for this to assess the TBS. No other device is required. And it can be affected by a very high obesity, degenerative spine changes. You can see the calcifications and all. And it does not replace BMD. It complements the BMD in assessing the bone density. And BMD measurement potential uses as screening for osteoporosis, as I said, and determining the fracture risk, identify the candidate for pharmacological intervention to prevent the fractures also. And the FRAX, another area is a fracture risk assessment tool. The country-specific threshold are available. India, you can see the data is available. You will have to fill in up all these things, and you will have to. The femoral neck BMD is only one that is taken into criteria, and you can select the BMD on that. And you can see the FRAX predicts a 10-year probability of hip fracture and a major osteoporotic fracture. And the Western data shows major osteoporotic fracture if it is more than 20% from this FRAX, and if the major hip fracture is more than 3%, then definitely a patient is at high risk for fracture and require pharmacological intervention. But FRAX is not validated for use with hip or lumbar spine BMD or for ethnic minority, for those receiving osteoporotic treatment, and for ages outside the age range of below 40 or above 90, it is not validated. And bone turnover marker, just touching it up, and again another latest one in the measurement is a biological assessment. You can measure it via the blood test. There are a bone formation marker and bone resorption marker. The resorption marker that we usually measure is bone CTX, C-terminal peptide, and the P1NP is the one, that is a type 1 procollagen peptide is the one that is used for assessing the bone formation marker. And again, it cannot be used to diagnose osteoporosis, but can predict more rapid rate of bone loss. It can again complement the BMD and also help in assessing how what is happening in the bone, whether the bone formation is discrete or whether the bone resorption is more. That will help in choosing the therapy also. And usually you can see in treatment aspect when you come, the bone density you can measure only after maybe a year, 1 year or 2 years, you will be able to see the change that is happening in the bone. But bone turnover marker will help in assessing the change in the bone density even as early as 3 months. So that is one advantage with the bone turnover marker. Yes, little bit costly here. I think one marker will cost around 2,000 to 2,500 rupees. And the fracture risk classification, I'm not going to detail, they can classify into low risk, moderate risk, and high risk, and very high risk. With a very high risk means multiple spine fracture or multiple fractures with a BMD T-score minus 2.4 or below is classified as a very high risk for the osteoporotic fracture. And coming to the treatment aspect, there are non-pharmacological and pharmacological. Non-pharmacological is also very important to reduce the fracture risk. The goal is to maintain the skeletal mass, reduce age-related bone mass, preserve the skeletal integrity, and even prevent the fall and fracture. So that is where the preventing the fall, the non-pharmacological measure holds good. And adequate calcium and vitamin D intake, weight-bearing exercise, very important. We Indians, and the muscle strength is definitely one thing that is very much low. Limiting the alcohol and caffeine consumption, and also the fall prevention techniques, it's also very important. And vitamin D level cutoffs, these are various guidelines showing what are the cutoff for the vitamin D to be kept. And the replacement we already discussed in the previous session. I'm not going into this. Is just the recommended daily allowance of the various calcium for each age group. For you can see those above 50 to 1,200 milligram of elemental calcium is required for the daily intake. And various preparation of calcium and how much calcium in calcium carbonate is the one that we commonly use. 1 gram of calcium carbonate is 400 mg elemental calcium. And 1 gram of calcium citrate malate contains 211 milligram of elemental calcium. And the other ones are, I'm not going to detail, the common one preparation only said. And fracture risk reduction with calcium alone, no, it's not very significant. With vitamin D alone, very inconsistent data on all the fracture risk reduction. Calcium plus vitamin D in elderly or high risk group, hip fracture, minimal or no reduction, vertebral fracture, modest reduction only, and non-vertebral fracture, some 10 to 15% in some studies, again, very inconsistent data that shows that calcium vitamin D supplementation alone is not going to cut down the fracture risk. You need some anti-osteoporotic therapies also in this sort of patients. Caffeine limitation is very important. Protein intake we have to increase at least you can see 0.8 gram per kilogram. If you can take it up to 1 gram or 1 to 1.2 is also quite good. Now, reduce alcohol consumption. Smoking is also has to be cut down. And exercise, yes, regular exercise, as we say, at least 30 to 45 minutes per day is very important. Preventing falls, so prevention of falls is very important. Anti-slip techniques in the inside the house, inside the washrooms or the toilets are all very important. And who needs pharmacological therapy when the osteoporosis minus 2.5 or below with the fracture risk is there, definitely you can treat. Even osteopenia with the TBS is poor, definitely you can treat. And T-score is -1 to -2.5, the FRAX is high, definitely then also you can treat the patient with the anti-osteoporotic therapy. Anti-osteoporotic therapy, yes, there are anti-resorptive agent and anabolic agent. That means reducing the resorption. Bisphosphonate, common one, we have studied even from the MBBS days. Then denosumab, as one doctor asked previously, denosumab is also available. Then the SERMs, the selective estrogen receptor modulators. Strontium calcitonin, we are not using it in our clinical day-to-day practice. So mainly it comes down to bisphosphonates or denosumab, and sometimes SERM in selective setting. Anabolic agent, teriparatide, romosozumab. Now romosozumab is available in India also. Previously it was not available. Now past 6 months to 1 year is now available. Abaloparatide, again PTHRP analog, not available in India. Bisphosphonate, yes, we can see there are oral and IV bisphosphonate are available. And except bandronate, all others can be used for treatment of the postmenopausal osteoporosis. But now with the convenience with the zoledronic acid available cheaply for 2,500 to 3,000 rupees per year only. So it is very affordable. Mostly we are using IV bisphosphonate and very potent also. And this is a dosing, you can see a zoledronic acid prophylactic dose 5 mg IV once in every 2 years, or usually yearly is the treatment dosage that we use. Prophylactic is once in 2 years, and the creatinine clearance need to be above at least 35. And the fracture risk reduction, you can see here the zoledronic acid, yes, vertebral fracture 70% reduction, non-vertebral 40%, and even hip fracture. So very good agent in reducing all the entire fracture risk. You can see bandronate, that is why it does not reduce the hip fracture, that is why it's not used for the postmenopausal osteoporosis. And oral bisphosphonate, alendronate is the one that has the highest data, but the problem with the oral bisphosphonate, we know the gastric erosion, esophagitis and all can happen. So we are not using these days. IV bisphosphonate is very less, the side effects also, the zoledronic acid, mostly sometimes flu-like reaction patient might develop 24 to 48 hours after taking the IV zoledronate, which can be managed with just a paracetamol. The risk, then the one is osteonecrosis, very, very rare complication. That can be also be higher because the zoledronic acid has a highest potency, so that can also be highest with the zoledronic acid. This is osteonecrosis of the jaw. And but American Dental Association does not recommend stopping bisphosphonate dental procedure. If a tooth extraction or implant is planned or ongoing, initiation of potent anti-resorptive therapy could be deferred. I mean, if you're, it's coincide with the time, we can defer the therapy, and then after the dental procedure you can proceed. But in other words, you can just monitor if the patient is developing any ONJ. And atypical femoral fracture, again another complication that can happen with the long-term bisphosphonate therapy. You can see the atypical fracture at the not at the neck of femur, it can be happen at the shaft of femur. You can see, and it might require even sometimes intramedullary nailing as part of the treatment for the atypical femoral fracture. And duration of therapy, oral therapy, moderate to low risk, can continue to 3 to 5 years, parental up to 3 years, and if necessary, a drug holiday. If the high risk patient, the parental can be given up to 6 years, and then a drug holiday as on case-to-case basis. And denosumab, first biological agent for osteoporosis, yes, the freedom trial, and it is FDA approved also, reduce the vertebral hip and also the non-vertebral fractures also. Good agent, 60 mg subcutaneous, every 6 months is the dosage, pre-filled syringes are available. It costs, even the generic denosumab costs around 10,000 rupees, so yearly it will cost you around 20,000 rupees. And no dose adjustment in the renal setting, so that is also an advantage. CKD stage 5 or on dialysis used with caution, because not because it can damage the kidney, but it can increase the risk for the hypocalcemia, which can happen even with the advanced CKD. And treatment cessation is associated with a decrease in BMD after 12 to 18 months and an increase in bone turnover marker at 3 to 6 months. So we should be very much cautious after stopping the denosumab. You should be giving at least some bisphosphonate shot, or else whatever positive thing that has been gained, that will be lost. SERMs, not very commonly used. The raloxifene is one that is approved. Some trial data are also available. And then conjugated estrogens also they can available, and HRT also can be used in early postmenopausal female, even those who are having hot flushes and other vasomotor symptoms. Then calcitonin, again we are not using it much as an anti-osteoporotic. Then other some agents that came and went away, cathepsin K inhibitor, SRC kinase inhibitor, strontium, not approved because of the other problems, and overestimation of BMD can also happen if the patient is on strontium. Teriparatide, very good agent. We are using these days as a bone formation marker, a bone formation therapy, osteoblastic activity is increased, and 20 microgram once daily is the dosing, as it can be taken subcutaneously. And only thing is that you should measure the calcium, PTH and vitamin D level before starting the treatment with the drug. And excellent data, supportive, and total duration 2 years. And there was a preclinical study showing high risk for osteosarcoma, but now that warning has been taken away. And after 2 years, if the patient is on high risk for osteoporotic fracture, you can continue is what the box has now, even the FDA has also given the and then the about teriparatide in patients with Peyer's disease of the bone, unexplained ALP elevation, prior skeletal radiotherapy, metastatic bone malignancy, or even primary hyperparathyroidism. So that is why PTH measurement before starting therapy is important. Abaloparatide not available in India, just for your knowledge. It is a PTHRP1 analog and even FDA approved for osteoporosis. And it is injectable single-use pen and 80 microgram daily is a dosing. Again, data are available, and you can see the no statistically significant difference in vertebral fracture was found between teriparatide and abaloparatide. Only thing was that abaloparatide lower risk for hypercalcemia during the therapy compared to the teriparatide. Romosozumab now available in India, human monoclonal antibody. It's act via the sclerostin pathway. Again, the frame trial has shown the benefits with the drug. And it can reduce the new vertebral fracture at 12 months, and no significant risk difference in the risk of non-vertebral or clinical fracture at 24 months. And you can say good increase in the BMD at all the sites. And but only thing is that it is approved for, I mean, you can use it for 1 month for improving the bone density. After that, there is a small concern with the cardiovascular risk with the romosozumab, because some studies have shown that increase the risk for the major adverse cardiovascular events. So you should be very careful on that. Then there are some agents that are still under phase 2 trial and all, not going into the detail. Monitoring with the DEXA at least yearly can be done, or even bone turnover marker as we discussed. And if there is a failure of treatment, you should reconsider your diagnosis, or whether the treatment also has to be changed from anti-resorptive to anabolic, or anabolic to anti-resorptive. Anabolic to anti-resorptive is good, but anti-resorptive to anabolic change is not much effective. You can see most studies show that blunting in BMD increases when teriparatide is given after bisphosphonate. So after anti-resorptive, giving an anabolic is not going to be that much effective. Denosumab to teriparatide, the switch, 6-month decline in spine BMD, but more extensive and progressive loss at the hip and the distal radius. So again, after denosumab, you should not be giving a teriparatide. Again, the bone will be lost. The accelerated bone remodeling will avoid prescribing this specific drug transformation of denosumab to teriparatide. And drug selection based on the fracture site, and you can see the fracture is predominantly vertebral fracture, you can choose anabolic agent, that is a teriparatide or romosozumab. Predominant hip fracture, you can choose anti-resorptive agent, commonly the bisphosphonate, or even denosumab available. Multiple or recent fragility fracture, anabolic followed by anti-resorptive. And younger postmenopausal women, you can consider even the SERM or even the HRT. And most important overall drug, it is romosozumab, high BMD gain even within 12 months time. That is why it is considered most important. Best for adherence issues, olorunric acid, single shot a year, the patient will also be happy, and cost effective also. Best in CKD, denosumab, and best for severe or multiple fractures, teriparatide or even romosozumab. And denosumab never stop abruptly, should be followed by anabolic, always follow the anti-resorptive, and bisphosphonate only class with a drug holiday, and romosozumab has the fastest BMD gain but with a CV caution. So this is the algorithm. I'm not going to detail due to short of time. So to take home message will be osteoporosis is definitely a neglected problem. So as clinicians, we should not be neglected. We should try to gain more knowledge on this aspect, and we can help our patients from reaching the orthopedic surgeon's table. And new effective anti-resorptive and osteoanabolic